불 깜빡깜빡하면 찍히는 거다. 한다.
Good morning, everyone. I am Hanali Ong, and I will be discussing on the second half of the cardiovascular disease and risk management. So, this will be the flow of my discussion. Starting off with their antiplatelet agents, the guidelines recommend the following: aspirin as a secondary prevention strategy in those with diabetes and history of atherosclerotic cardiovascular disease, clopidogrel for patients with atherosclerotic cardiovascular disease and documented aspirin allergy, dual antiplatelet therapy with low-dose aspirin and P2Y12 inhibitor is reasonable for a year after an acute coronary syndrome and may have benefits beyond this period. And lastly, aspirin therapy may be considered as primary prevention strategy in those with diabetes who are at increased cardiovascular risk, considering that this is after a comprehensive discussion with the patient on the benefits versus comparable increased risk of bleeding. Aspirin has been shown to be effective in reducing cardiovascular morbidity and mortality in high-risk patients with previous MI or stroke in secondary prevention and is strongly recommended. In primary intervention, however, among patients with no previous cardiovascular events, its net benefit is more controversial. Aspirin appears to have a modest effect on ischemic vascular events, with absolute decrease in events depending on the underlying ASCVD risk. The main adverse effect is an increased risk of gastrointestinal bleeding. So, the recommendations for using aspirin as primary prevention include both men and women aged 50 years old and above, and at least one additional major risk factors, including your family history of premature ASCVD, hypertension, dyslipidemia, smoking, or chronic kidney disease or albuminuria, and a special mention that those who are not at increased risk of bleeding, for example, older age, anemia, or renal disease. Non-invasive imaging techniques such as coronary calcium scoring may potentially help further tailor aspirin therapy, particularly in those at low risk. For patients over 70 years old with or without diabetes, balance appears to have greater risk than benefit. Thus, for primary prevention, aspirin needs to be carefully considered and may generally be not recommended. For patients with documented ASCVD, use of aspirin for secondary prevention has far greater benefit than risk. For this indication, aspirin is still recommended. Aspirin is not recommended for those at low risk of ASCVD, such as men and women aged less than 50 years old with diabetes with no other major ASCVD risk factors, as the risk of bleeding outweighs the benefits. Aspirin use in patients aged less than 21 years old is generally contraindicated due to associated risk of Ray's syndrome. Average daily dosages used in most clinical trials involving patients with diabetes ranges from 50 to 650 milligrams, but were mostly in the range of 100 to 325 milligrams per day. Using the lowest possible dose may help reduce side effects. In the US, the most common low-dose tablet is 81 milligrams. It appears that 75 to 162 milligrams per day is optimal. A P2Y12 receptor antagonist in combination with aspirin is reasonable for at least 1 year in patients following an ACS and may have benefits beyond this period. If no percutaneous coronary intervention was performed, evidence supports use of either ticagrelor or clopidogrel. If a percutaneous coronary intervention was performed, clopidogrel, ticagrelor, or prasugrel may be used. In patients with diabetes and prior MI around 1 to 3 years before, adding ticagrelor to aspirin significantly reduces the risk of recurrent ischemic events, including cardiovascular and CHD death. Now going to the cardiovascular disease. These are the recommendations in screening for cardiovascular disease. In asymptomatic patients, routine screening for coronary artery disease is not recommended as it does not improve outcomes as long as atherosclerotic cardiovascular disease risk factors are treated. Second, consider investigations for coronary artery disease in the presence of any of the following: Atypical cardiac symptoms, for example, unexplained dyspnea or chest discomfort, signs or symptoms of associated vascular disease, including carotid bruit, transient ischemic attack, stroke, claudication, or peripheral arterial disease. Lastly, your electrocardiogram abnormalities, for example, Q waves. The following are the recommendations in treatment for cardiovascular disease. Consider ACE inhibitor or angiotensin receptor blocker therapy in patients with known atherosclerotic cardiovascular disease to reduce the risk of cardiovascular events. For patients with prior myocardial infarction, beta blockers should be continued for at least 2 years after the event. Patients with type 2 diabetes with stable heart failure may continue metformin for glucose lowering if estimated GFR remains more than 30 ml per minute, but should be avoided in unstable or hospitalized patients with heart failure. Among patients with type 2 diabetes who have established atherosclerotic cardiovascular disease or established kidney disease, sodium glucose cotransporter 2 inhibitor or glucagon-like peptide 1 receptor agonist with demonstrated cardiovascular disease benefit is recommended as part of the glucose lowering regimen. And this table shows the specific recommendations under the previous slide. For the first row, sodium glucose cotransporter 2 inhibitor with demonstrated cardiovascular benefit is recommended to reduce risk of major adverse cardiovascular events and heart failure hospitalizations. For the second recommendation, glucagon-like peptide 1 receptor agonist with demonstrated cardiovascular benefit is recommended to reduce risk of major adverse cardiovascular events. For the last row, sodium glucose cotransporter 2 inhibitor may be considered to reduce risk of heart failure hospitalization. Moving on to cardiac testing. So the candidates for advanced or invasive cardiac testing include those with first, typical or atypical cardiac symptoms, and second, an abnormal resting electrocardiogram. Exercise ECG testing without or with echocardiography may be used as the initial test. In adults with diabetes 40 years of age and above, measurement of coronary artery calcium is also reasonable for cardiovascular risk assessment. Pharmacologic stress echocardiography or nuclear imaging should be considered in individuals with diabetes in whom resting ECG abnormalities preclude exercise stress testing. In addition, individuals who require stress testing and are unable to exercise should undergo pharmacologic stress echocardiography or nuclear imaging. Screening of asymptomatic patients with high ASCVD risk is not recommended in part because these high-risk patients should already be receiving intensive medical therapy. While coronary artery screening methods such as your calcium scoring may improve cardiovascular risk assessment in people with type 2 diabetes, their routine use leads to radiation exposure that may result in unnecessary invasive testing such as coronary angiography and revascularization procedures. Intensive lifestyle interventions focusing on weight loss through decreased caloric intake and increased physical activity may be considered for improving glucose control, fitness, and some ASCVD risk factors. Patients at increased ASCVD risk should receive statin, ACE inhibitor, or ARB if the patient has hypertension and possibly aspirin, unless there are contraindications. In patients with prior MI, active angina, or heart failure with reduced ejection fraction, beta blockers should be used. Now going to the last topic on glucose-lowering therapies and cardiovascular outcomes. So glucagon-like peptide receptor 1 agonists and SGLT2 inhibitors reduce risk of atherosclerotic major adverse cardiovascular events to a comparable degree in patients with type 2 diabetes and established ASCVD. Starting off with SGLT2 inhibitors, there are actually three FDA-approved drugs, which are your empagliflozin, canagliflozin, and dapagliflozin. These appeared to reduce risk of heart failure hospitalization and progression of kidney disease in patients with established ASCVD, multiple risk factors for ASCVD, or diabetic kidney disease. GLP-1 receptor agonist has 4 FDA-approved drugs, which include liraglutide, albiglutide, which was removed from the market, semaglutide, and dulaglutide. This demonstrated cardiovascular benefit in patients with type 2 diabetes and established ASCVD or multiple risk factors for ASCVD. So it is recommended to reduce risk of major adverse cardiovascular events. In glucose-lowering therapies and heart failure, data demonstrated that thiazolidinediones increase risk of heart failure, thereby it should be avoided in patients with symptomatic heart failure. Metformin may be used for management of hyperglycemia in patients with stable heart failure as long as kidney function is within the recommended range of use.